the first treatment is antigen avoidance, and we give steroids always. So if disease is still progressing, normally it moves towards fibrotic, but we had 1 or 2 patients where we were not able to identify the antigen and it was still non-fibrotic and disease was progressing, the FVC was declining. Then we used the MMF.
Thank you very much. Very nice presentation. Sir, in case of acute HP, if we are not able to identify the allergen and the presentation, the patient has significant symptom, then what would be the treatment and what would be the duration of the treatment?
So again, the first part is antigen removal, right? So at times, if possible, especially you are talking about acute. In acute, normally the exposure is acute and some symptom they develop soon after the exposure. So in non-fibrotic, so it is slightly easier to identify exposure. If we are not able to identify, we can maybe try, say, some housewife developing. We can ask her to change the residence, because more often than not the exposure is happening at the home only. So then we start the corticosteroids.
Duration of the corticosteroid therapy. What would be the duration of the corticosteroid therapy?
So in non-fibrotic, the duration is not very long, maybe few 2-3 months only, not very long.
Thank you, Dr. Naveen. It was
Thank
an
you.
excellent disposition.
Thank you.
Now we move on to the next talk, and I invite Dr. Shejal Dhuria to present his talk on autoimmune related ILD. We have already heard him in a session before this, so I'll skip the intro part. Dr. Shejal.
Thank you, chairpersons and organizers. So, my topic is management of autoimmune related ILDs. I'll restrict myself to treatment. That's what I understand by the word management. And about 2 years back, my lecture looked very different for the treatment of ILDs. But 2 years back, we have got this particular guideline, which actually got published last year. And this has not been discussed too many times in many fora that I've seen. So I'll take the opportunity to just introduce to all the students the major recommendations of this guideline, because before this we didn't have an evidence-based, a good expert group-based guideline on CDD-ILDs or autoimmune-related ILDs. They've used the term systemic autoimmune rheumatic diseases for what we call CDDs or autoimmune-related ILDs. So the first line treatment options for systemic autoimmune related disease or CTD-ILD, they have given a conditional recommendation for glucocorticoids. Most of the recommendations in this guideline are conditional, 1 or 2 strong recommendations only, and all of them are based on low quality evidence, because there have been few RCTs. There have almost been less than 10 good RCTs of immunosuppressants in CTD-ILD, which I'm going to discuss along the way. So the first recommendation is about the first line treatment of CTD-ILD, and the guidelines say that we may use glucocorticoids, but not in scleroderma ILD or systemic sclerosis, because with scleroderma, the use of any steroid dose above, say, 10 to 15 milligrams may be associated with the risk of scleroderma renal crisis. So that's why CTDs other than scleroderma, we might use glucocorticoids as first line agent. There are no large trials on glucocorticoids. It is based on just the pathogenesis, the usual mechanism of action of glucocorticoids in suppressing immunity. The other recommendation is for the use of cyclophosphamide and azathioprine for CTD-ILDs. This is based on the SLS1 trial, which was published more than 1.5 decades or 2 decades back, where there were about 150 patients of scleroderma. They were given cyclophosphamide or placebo for about a year. And with cyclophosphamide, there was a modest improvement in forced vital capacity. So based on this trial and the large clinical experience and observational studies, cyclophosphamide has been the drug of choice in inducing remission of an active scleroderma where there is significant lung disease or other kind of systemic involvement which is significant. But with times, as mycophenolate, the drug mycophenolate sodium or mycophenolate mofetil came along, there was another trial which is called the scleroderma lung study 2, wherein mycophenolate was compared with cyclophosphamide, and it was observed that the FVC change in both the arms was similar, and this was a 2-year study. The FVC change was about 2 to 3% in either arms, and the secondary outcomes were also similar, but mycophenolate was associated with fewer infections. So after this trial, the SLS2 trial, there has been recommendation that mycophenolate works as effectively as cyclophosphamide, but may be safer. So since that time, we have been using mycophenolate mofetil as our first line treatment for most of the CTD ILDs, especially scleroderma ILD. The other drug which is coming into common use is rituximab. Rituximab is relatively easy to deliver because you just have to give 2 doses 2 weeks apart initially, and then you can take a call on the maintenance treatment at 6 monthly intervals. Although it needs a workup of underlying chronic infections, it may be associated with serious suppression of immunity. But with the large experience amongst rheumatologists, rituximab has been a safe to use drug. This recommendation, conditional recommendation for rituximab in CTD ILDs comes from this particular trial, which is called the Recital trial, published about 2 years back, where there were about 100 patients of different CTDs like inflammatory myositis, scleroderma, and mixed connective tissue disorder. Here, rituximab was compared with cyclophosphamide, and it was a 6-month trial. It was a superiority trial, like it was tested whether rituximab is better than cyclophosphamide. But this trial found out that rituximab is not better than cyclophosphamide, but almost works equivalently. So rituximab becomes another first line option for treating CTD related ILDs. There were also fewer adverse events in the rituximab arm in this particular trial. The other trial, which is based on the effect of rituximab in CTD ILD, is the EVER ILD trial, also done a couple of years back. And here they enrolled patients with an NSIP pattern of causing CTD or idiopathic or interstitial pneumonia with autoimmune features. So some of them were idiopathic NSIP, some of the patients were actually NSIP pattern. And here they gave MMF with rituximab in one of the arms. The other arm received MMF with placebo. So essentially MMF alone. So in the MMF alone arm, there was a decline of FVC by 2%. In the combination arm, there was an improvement in FVC by about 2%, 1.6%. The HRCT remained stable. There were similar adverse effects. So it seems that rituximab and MMF combination is superior to MMF alone in ILDs with an NSIP pattern. So from this trial, you can conclude that you can either use a combination of both or maybe rituximab alone rather than using MMF alone. So we now have 3 major options in CTD ILDs as first line agents apart from glucocorticoids, and that is cyclophosphamide, MMF, rituximab. So in our clinic, we decide the first line agent based on the patient profile, the expected side effects profile, how the tolerance will be for that patient, and the finances involved. So rituximab will cost about between 15 and 25,000 rupees for its first 2 doses, while cyclophos will cost hardly say less than 5,000 rupees for the entire course for 6 months. Mycophenolate again is an expensive drug with a therapy related cost of 7,000 to 10,000 rupees per month. The other option that the guideline has recommended apart from MMF as a rituximab and cyclophosphamide is azathioprine, which just is a continuation therapy after cyclophosphamide induction. But there are agents which the guidelines recommend against. So these are leflunomide, methotrexate, TNF inhibitors, abatacept, IVIG, and plasma exchange. These should not be used as first-line agents in CTD ILDs. Although there is some data that methotrexate may be effective as a treatment for ILD, but there are fears of methotrexate related pneumotoxicity, which prevented at least this group of experts to recommend the use of methotrexate for ILD. Although in sarcoidosis, we commonly use methotrexate as a second line agent. For scleroderma ILD particularly, there is a strong recommendation against glucocorticoids, as I said, because it can cause scleroderma renal crisis. But there is a conditional recommendation for using nintedanib as a first line agent. And the evidence comes from this trial, which is called the Census trial, published about 5 years back, a phase 3 RCT. This was the largest RCT performed in CDD-ILDs, about 600 patients, where nintedanib was given as a first line agent. And in the nintedanib arm, the decline in FVC over 1 year was about 50 ml. In the placebo arm, it was about 90 ml. So the difference was about 40 ml, which was statistically significant, just about significant. But clinically, it may not be significant, because clinically, we presume that at least a difference of 100 ml is required to make a clinically meaningful difference. But this was a 1 year trial, and if you could extrapolate that data to say 2 years, as it was in the SLS trials, because scleroderma ILD progresses slowly, so had the trial been performed for 2 years, we could have seen a better difference. So those kinds of explanations are given by the trialists and the experts. So even without a clinically meaningful difference, the experts have recommended that nintedanib can be used as a first line agent to treat scleroderma related interstitial lung disease. The other recommendation is for tocilizumab, and this recommendation is both for scleroderma and mixed connective tissue disorder related ILD. Tocilizumab is an anti-IL-6 agent. The evidence comes from two trials. One was a phase 2 RCT of tocilizumab, the other was a phase 3 RCT. The phase 2 RCT is called the Fascinate trial, published about a decade back, and Focus trial, published about 4 years back, which is the phase 3 RCT. The first trial has about 90 patients, the other trial has about 210 patients. So here the primary outcome was skin disease. So the skin thickening score, which is called the modified Rodnan skin score, was taken as the primary objective or primary outcome of the trial. Between tocilizumab and placebo, there was no difference in the skin outcome. So actually the trial had a negative result, and final negative result. But lung function was a secondary outcome in which there was a significant difference between tocilizumab and placebo. So based on these two trials, the experts have recommended that tocilizumab may also be used as a first line option for treating scleroderma ILD and mixed connective tissue disorder related ILD. For myositis related ILDs, there has been a conditional recommendation for JAK inhibitors, which is tofacitinib, and calcineurin inhibitors, which is tacrolimus. So these two drugs, which pulmonologists hardly use, even I have used just in 1 or 2 cases, but I plan to use more of it in the coming future. So this can be used for myositis ILD, but the experts recommend against using it in other forms of CDD ILDs. So there is observational data in myositis ILD, no RCTs, but for other ILDs, these should not be used as first line agents. Regarding antifibrotics, as we discussed that for scleroderma ILD, nintedanib may be a first line treatment, but for other ILDs, generally these are not used as first line agents. Upfront combination of nintedanib and MMF is also discouraged. And for other CDD ILDs, either there is no recommendation or a recommendation against using an antifibrotic as a first line agent. So remember, if you see a UIP pattern, as we discussed in my lecture also, if you see a UIP pattern, if you believe this might be CTD related, so better to go ahead and prove that it is a CTD related ILD, because the management is going to differ. For IPF, you will start with an antifibrotic. For a CTD ILD, you will start with an immunosuppressant, and the experts recommend against starting with an antifibrotic. If progression occurs despite first line treatment, progression means a 5% change in the percent predicted FVC, then you can use agents like, again, mycophenolate, rituximab, and cyclophosphamide. So these are the top 3 agents after glucocorticoids. So if you have used one, say MMF, and progression occurs, you can switch to rituximab. Long-term glucocorticoids should not be used because they are associated with lots of adverse effects. Plasma exchange should not be used for progressive disease. And then if there is scleroderma or mixed connective tissue disorder or rheumatoid, tocilizumab again can be used as an agent if the first line therapy like MMF has failed. So again, similar recommendations for myositis, as we saw that JAK inhibitors like tofacitinib and calcineurin inhibitors like tacrolimus can be used mainly for myositis related ILDs and not for other ILDs. And if progression occurs despite immunosuppressants in any of the CTD ILD, then nintedanib is the preferred drug to be used for progressive pulmonary fibrosis. And the evidence comes from the inbuilt trial, which Dr. Naveen also showed. So if there is progression despite the standard treatment with immunosuppressants, nintedanib may be effective in this trial. In the nintedanib arm, there was an 80 ml decline over 1 year, while in the placebo arm, there was a 180 ml decline. So nintedanib does prevent a faster lung function decline in CTD ILDs that have progressed on immunosuppressants. So again, a few recommendations which are very similar to the ones we have discussed. I'll just skip this part. And then the final section in this guideline is about rapidly progressive ILD. So rapidly progressive ILD means if an ILD progresses from the onset of symptoms to say respiratory failure or grade 3 dyspnea over a short period of time, mostly 4 to 8 weeks, then it is called rapidly progressive ILD. There is a form of RP-ILD which is associated with anti-MDF5 antibodies. There can be some anti-synthetase syndrome or myositis related ILDs which are associated with a rapid progression. So in that case, the experts recommend that there should be a use of more than one agent in one go. So you should start with say a pulse steroid and combine with it either rituximab or cyclophosphamide or both. So multiple strong anti-inflammatory agents or immunosuppressant agents should be used for rapidly progressive interstitial lung disease because there is intense immunological inflammation in the lungs and it is very refractory to the simple use of one agent. So a triple or a double therapy should be used for these kinds of interstitial lung diseases. And then the ancillary management, which Dr. Naveen also touched upon a bit. So it can be remembered with this mnemonic: comorbidity management, rehabilitation if there is advanced disease, oxygen therapy for hypoxemia, immunization for influenza, for pneumonia, and for even varicella. Then symptom control and palliative care for advanced dyspnea, smoking cessation if a person is smoker. Antigen exposure avoidance in general should be kept in mind for any kind of ILD, but less so in CTD ILDs. Nutrition counseling is important. And then finally, lung transplantation if there is end stage lung disease. So to summarize, you can just look at this kind of these kind of diagrams which the guideline also provides, and you can actually take a printout and paste it in your OPD so that you can refer to it easily. So there are 5 kinds of CTDs that the guideline has dwelled upon. As we discussed, scleroderma, myositis, MCTD, rheumatoid, and Sjogren's. In all of these, the first line preferred agent is mycophenolate, but rituximab also figures as a alternate agent, and then cyclophosphamide also is a additional option. So these 3. Apart from that, for scleroderma, there is tocilizumab as a first line agent for scleroderma and for MCTD. But there is a strong recommendation against using glucocorticoids, especially high dose, in scleroderma. And once progression occurs, again, mycophenolate, rituximab, and cyclophosphamide remain in the picture for management. But then nintedanib should be used if there is progressive fibrosis. And there is recommendation against long-term glucocorticoids in most of these disorders because here immunosuppressants are needed for years together, sometimes for life, and glucocorticoids are associated with severe side effects once used for a longer period. So it's better that we move on to steroid sparing agents early. And then finally, advanced disease requires lung transplantation. And if there is rapidly progressive ILD, use glucocorticoids in IV pulse form but also combine with it a calcineurin inhibitor and rituximab, or a combination of any of these two. So there are 2 or 3 agents that you will straight away give if there is rapidly progressive ILD. So if you see a patient who lands up into your ICU with hypoxemia with just 1 month of onset of his symptoms and you have ruled out infections as the cause, then you should send an MDA5 antibody, send an antisynthetase or myositis panel, and give the patient intense immunosuppression. And despite that, there is 40 to 50% mortality in such ILDs. Thank you.
Thank you, Dr. Sejal. And before we throw it open for the audience, just a query. Consider a case of rheumatoid arthritis on treatment with methotrexate and he develops ILD. So how would you differentiate whether it is drug induced or whether it is disease induced?
Make 100% differentiation even for experts, even if you do a large surgical lung biopsy. But there are certain thumb rules which we tend to follow and experts also follow. So if there is a rheumatoid disease of longer duration and the patient is getting methotrexate over years and the patient develops insidiously a UIP pattern. So it is most likely due to the disease itself. It's a CTD related ILD rather than methotrexate induced ILD. But if you have started methotrexate recently over the last few weeks, days, weeks, or months, and if an acute ILD pattern develops, for example, in the form of ground glass opacities, giving rise to an NSIP pattern, or even an HP pattern, organizing pneumonia pattern, then there is a chance that rituximab may be methotrexate may be responsible for this kind of a pneumonitis. And there it is better that you stop methotrexate. If you do a biopsy in such cases, you may get non-specific patterns. Sometimes you might get eosinophilia. Sometimes you may get a hypersensitivity pneumonitis-like pattern due to the drug, but it is not always that you will get these patterns. So it's always a test of probabilities, a matter of experience that you decide what to do about it. But any long-standing rheumatoid, a long-standing, a protracted long methotrexate, and that patient developing a fibrotic pattern of ILD, it is mostly due to the disease and not the drug.
Even if the activity is well controlled with methotrexate, would you consider that the disease is
Yes,
taking?
even if the articular activity is well controlled, an ILD can still crop up. If the sometimes the activity is on the surface controlled, but if you do further investigations, you'll find that it is not really controlled. Even the joint activity, the patient may be okay that okay, there's small pain, he may ignore it. If you do an MRI, there is inflammation. So it is more based on experience rather than any definite kind of proof that we can
Well
get.
said. And would you
clinically.
like to remove the methotrexate and shift on to other drugs?
Again, it's a difficult question and it needs a very practical answer because some experts will take away methotrexate because we have so many agents, other agents which we can use. For example, when we had only methotrexate and azathioprine, it was a difficult dilemma because azathioprine does not work well on joints. So when you have ILD and when you have joints, then azathioprine is not an option. So most clinician will move to cyclophosphamide induction if this kind of a thing occurs. Now we have rituximab, which is a very good agent. It controls the joint activity, it controls the lung activity. So it's a good idea to shift to rituximab.
Mike, somebody can.
Always. Okay, how frequently? So yes. So I have used very little of rituximab in CDD ILDs because several of our patients will not afford it. But we have a protocol that will always do a baseline serum total IgG. If it is less than 600, we might move on to another agent. If it is less than 300, then we have to investigate for say CVID, etc. Right? So one is that at baseline, but mostly whatever patients I got, they were all normal at the baseline. At the baseline, we also do a hepatitis B surface antigen, an anti-hepatitis C antibody, and an anti-hepatitis B core antibody. So these three we will always do because these are the recommendations. So once these are all normal, we go ahead with rituximab. And the guideline for monitoring is more like flexible. You might or might not do serum total IgG, but we always do in our practice. Mostly I do it at 2 to 3 months to see the immediate effect, whether it is really leading to a hypogamma globulinemia in that particular patient. Because if the patient is prone, immediately with the first course of 2 doses, he or she will show a decline. Later, mostly it is not required. If you want to do it, you can do it. Mostly after the subsequent doses, it may not be always required. But if it is low and you don't have another option of treatment, then you should replace with IVIG. Septran is the usual chemo prophylaxis, PCP prophylaxis, which I always use for all those who are getting immunosuppressants, any kind of immunosuppressants. Though rituximab mainly has its effect on the humoral immunity, but it also suppresses cell-mediated immunity. The other thing which we must always do is give vaccinations before we start any kind of strong immunosuppression. Yes. So MMF dose is 2 to 3 grams per day, at least 2 grams and better 3 grams in some of the cases. But steroids, you start at a dose which is required at right at the moment to suppress the immediate activity and control symptoms. So if it is like intensely inflammatory diseases, like for example myositis causing immediate muscle weakness, and you want an immediate kind of effect so that the patient just gets up from the bed. So there you tend to use a higher dose initially, maybe a 1 milligram per kg dose or even a pulse. But in other diseases like rheumatoid, developing a UIP pattern or a fibrotic NSIP pattern, we tend to give smaller doses, 0.5 milligram per kg or less than that. And then let the steroid sparing agent have its effect over the next 2 to 3 months. Yes, sir. Mhm. Mm. Yes. Mm. Mhm. So the best, see, whenever you are starting immunosuppression, at least the vaccine should have a duration of 4 to 6 weeks to have its immunogenicity, right? So if the best protocol to do this practically in your OPDs, the moment you see a chronic respiratory disease, you immediately administer vaccination. By the time you work that patient up for the diagnosis, all the investigations, 4 weeks will be anyways be over. By that time, you'll be able to use any kind of immunosuppressant. But if it is an urgency, as sir said, that if it is urgent, then you might need to avoid that vaccination immediately. And when the immunosuppression in the future is brought down in its intensity, then you might administer. That is the practical step. It's not like it's not the ideal, because you should give immunization as soon as possible and before immune suppression. In CDD, there is no guideline. In any kind of ILD, there is no guideline. So it is very individual specific, patient specific and clinician specific. But with CTDs, you should give a longer treatment rather as compared to say hypersensitivity pneumonitis or sarcoidosis. With CTD ILDs, you should at least aim for a 2 to 3 years of intense treatment. And then you might slowly taper down the treatment and take a informed decision along with the patient to stop that treatment and monitor very closely. Because if the systemic activity is not there or is controlled, then a rheumatologist will always intervene. But if it is a lung dominant CDD, and then it's your decision, and then you can take a call at about 2 to 3 years that whether you can bring down the immunosuppression to very low levels. For example, an alternate day steroid regimen, low dose, or a small dose of azathioprine or mycophenolate. So that is the practical step. We don't have RCTs to prove anything.
Thank you, Dr. Sejal. Excellent talk. We'll have it later. Thank you, Dr. Sejal.
Thank.
I invite my co-chair to introduce the next speaker.
Now, it's my pleasure and honor to introduce a highly esteemed personality in the field of pulmonary medicine, Dr. Anand Mohan sir, Dr. Anand Mohan sir is currently serving as Professor and Head Department of Pulmonary Critical Care and Sleep Medicine, All India AIMS. Welcome sir, welcome on the dais.
Thank you very much. And first of all, thank you to the organizing team, Dr. Alok, Dr. Mansi, and the entire team for inviting me here. Can we start? So, after hearing in detail and some excellent lectures on various aspects and various types of ILDs, we'll now come to a type of ILD which is relatively new, relatively described relatively recently, and something which has come up in the last couple of years only, and the term of progressive fibrosing ILD or PF-ILD or PPF also, as it is called. There are some subtle differences which we'll discuss. So over the next couple of minutes, I'll be talking about this particular entity and how we diagnose and treat it. So, again. So we'll start off with one prototype case of a middle-aged female who was diagnosed, actually who presented almost 7, 8 years ago in 2016 with dyspnea dry cough. And after workup, there were some typical findings. As you can see, ANA positivity was there and other things were okay. There was a restrictive pattern. The DLCO was also reduced and the 6-minute walk distance was also reduced. And this was the CT scan, and something which we see very commonly. You see the basically septal thickening is there, and there is a bit of traction, there are reticulations, and there is some amount of GGO as well. Based on all this, a diagnosis of ILD was made, and corticosteroids was started and gradually tapered, and also mycophenolate was also initiated at that point of time. After about a year or so, when the patient came back, there was improvement in the symptoms. There was some mild PH although, and the radiology at that particular time again showed some improvement as far as the GGOs and all the other things are concerned if we kind of compare with the 2-year older CT scan. The FVC was almost kind of similar, GLCO was almost similar, 6-minute walk test that had improved. Now, corticosteroids were tapered, maintained a little bit at 5 milligrams. The other immunosuppression was continued. Now, next year, the person comes with worsening of the symptoms for the last couple of months, and desaturation was there. The echo showed increased pulmonary artery systolic pressure. There was worsening of the respiratory functions, as you can see, and also of the 6-minute walk test. And here also, as you can see, again, there is some worsening on this side. And can we have the pointer, please? This one? This one? Yeah. So if you can see, though, this area is kind of worsening. This area also is slightly worsened if you have compared with the last one. Patient had to be started on oxygen, steroids, and all were already being given. At this point of time, antifibrotics were added. So this is just a practical, pragmatic kind of a thing. I'm not kind of discussing why and what should have been done, but these are type of patients that we get. And at this point of time, the diagnosis of a progressive fibrosing ILD was made. So now from here, let's take off and see what is this particular entity. So pulmonary fibrosis is basically a phenotype which has a distinct course and also a treatment pattern. There are several terminologies, and some of you might be getting confused with the type of terminologies PF-ILD, PPF, and so many things are there. So ILD, of course, is the blanket terminology, and IPF is also a typical entity, a classical entity of the fibrosing type of a ILD. So it is a prototype of the fibrosing ILD. These two entities are relatively new, PPF and the PF-ILD, and basically they are very similar, but just some subtle differences. And if we see this entity here, over here, if we see that pulmonary fibrosis, if this whole thing is pulmonary fibrosis, then there are so many causes of pulmonary the fibrosis occurring. They may be autoimmune, it may be HP, it may be medications, occupation, it may be the IPF pattern, or it may be because of smoking, and so many others. So various ILDs may ultimately have a fibrotic pattern or may ultimately fibrose later on. If you look at the prevalence of PF-ILD in various ILDs, generally speaking, it is approximately 2 to 28 per lakh population, a very wide range you might say, but that's how it is, because whatever limited knowledge we have. Again, if we see this red colored cracked circle over here, if everything inside this is supposed to be PPF, and the prototype will be IPF, in which a significant proportion forms the PPF. But even among all the other ILDs, including sarcoid, fibrotic, the HP, CTD ILD, undifferentiated ILD, and others, drug-induced, etc., you can see a proportion of them also go on to develop progressive pulmonary fibrosis or PF-ILD. And you can also see the range is so variable, right, from 1.5 to 47, depending upon the setting, the population tested, the modalities of investigation, etc. And that is why there is no clear-cut answer, but there is a wide range of how frequently a particular ILD can progress to fibrosis or fibrosing ILD. Thereby coming to a bit about the definitions. And if we define, so there is, I think, no doubt about this part. We all know about this, but it is about the PF-ILD and the PPF that we need to know. PF-ILD is basically an interstitial lung disease with a progressively fibrosing phenotype. It is more of a blanket term. It is a covering term of PPF. So it means a ILD which has pulmonary fibrosis in the parenchyma, which is progressing along with symptoms and declining lung function and other comorbidities like quality of life, etc. Now, PPF is a kind of sub variety of PF-ILD, in which it is also fibrosing ILD with a progression which is similar, more like an IPF. So it behaves more like an IPF. Causes may be many, and it is a sub variety of the PF-ILD. So the disease progression is because of progression not just in the interstitium but in other parts of the lung parenchyma. It follows a clinical course much similar to the IPF over here. So it is a relentlessly progressive kind of a fibrosis despite management, which is appropriate for that particular interstitial lung disease. So that is just a subtle difference between these two types of fibrosing ILDs. Then what do we define as progression? So that is another important thing. It is, so we should not loosely term or loosely classify any ILD as a progressive ILD. So there are certain criteria which have been laid out. Of course, this is all work in progress because this whole entity has been recognized in the last 5-6 years only. These are the major trials which were conducted related to this, and some of them have already been described, and these are some of the recent trials, 18, 19, 20, and then in 21. And you can see the criteria all of them have used for describing the progression of the ILD per se. All of them, virtually all of them, have relied on the FVC or the DLCO as far as the functional component is concerned, along with radiological progression. So some have used a relative decline of 10% along with a relative decline of DLCO of 15%. And in presence of worsening symptoms, this value is between 5 to 10% in presence of symptoms or radiological progression. This is the one trial which we'll discuss later also, which has used an absolute annual decline of FVC rather than the relative decline. And this is of 5% within 6 to 24 months of diagnosis. So again, FVC is the variable that we have to use to define progression. As of now, that is what is kind of the general consensus. And anything beyond 10% relative decline is considered to be a marker of progression in the presence of other compatible clinical and radiological features. So again, if we have to actually classify, actually define, so any ILD having a radiological evidence of pulmonary fibrosis other than IPF, right, along with any two of these three, either worsening symptoms, respiratory symptoms, physiological evidence of progression, which we have already seen, the FVC or the DLCO, and radiological evidence of disease progression. So any two of these three occurring within 1 year and with no other alternative explanation to explain whatever decline and worsening has taken place. So you rule out heart failures, pulmonary embolisms, rule out muscle weaknesses due to other causes, and rule out pulmonary hypertension and other things. Not just these, but many others. Once all that is ruled out, then one is justified in labeling a person as a progressive ILD, PF-ILD. So if we kind of summarize the classification criteria, clinical criteria as worsening symptoms, physiological criteria may be either one of those, either an absolute decline of FVC more than 5% within previous 1 year, or DLCO more than 10%, along with radiological criteria which may be either one of the following. And you can see that there are several criteria which have been listed out. If any of these is conclusively present along with any one of the other two, then we are justified in making a diagnosis of a PF-ILD. And this is just an example to show a radiological what are the changes which happen. Over here you can see this is the initial one, and then this is later on. You can see the progression of the fibrosis and traction bronchiectasis, almost like a honeycombing type of picture being kind of seen in the later CT scans. So this is all these things, or any of these may happen, and it's kind of important to recognize the features of chronicity. Again, this was already told by Dr. Naveen in his slide that radiologists do want some particular criteria to be met when we do a CT scan. So it should be a thin section of a CT scan. It's thin section, end inspiration without contrast, and ideally supine and prone both, so that we are able to detect or exclude air trapping and other things which may have some confounding effects. And if possible, we can do for monitoring purposes also, we can do the expiratory and the prone positioning. So these things one should be careful when we order a CT scan, then we should make sure that these criteria are met and taken care of. So once the diagnosis has been established, then we come to the main part, and how do we treat? Now treatment can be again basically pharmacological or non-pharmacological. Again, non-pharmacological is something that we are doing for most chronic respiratory diseases, and the principles remain more or less the same. So the focus here would be more obviously on the pharmacological aspects, and among those we have the antifibrotics, we have the immunosuppressive. So the treatment of the original ILD which was there, if it is still active, it should continue. That is one thing. Anti-GERD measures to take care of the pulmonary hypertension. And then I will also talk about a bit about some experimental newer therapies which are under trials, because this is a kind of a CME, so a lot of postgraduates, you should know what are the newer things which are coming up. In the next couple of years, we might be seeing more of those. So we should also know now, how does fibrosis evolve and how much time it takes for fibrosis to occur. These are very general kind of things. This may differ from patient to patient, but broadly speaking, if the initial symptoms of ILD are starting over here, approximately 9 to 11 months is the time it takes to actually diagnose. So almost a 1 year it takes from the onset of symptom to the actual diagnosis of the ILD. And these are the different type of ILDs. After that, how much time it takes to develop fibrosing kind of a progressive fibrosing kind of ILD, again almost 1 to 1.25 years it takes. And then after that, it is relentlessly progressive, and the physician detection also takes approximately another 1 year time. So this is the time when we have a window of opportunity. If we can reduce this time to the minimum possible, it gives us the chance to act at this point and prevent any further damage. And you know that the average time basically to mortality is ranging anywhere between 3 to 5 years, depending upon the type and the extent. So utilizing the window of opportunity, we do assume that the antifibrotics which prevent the decline of FVC and IPF would also do the same in PPF and PF-ILDs. And right now we have only 2 antifibrotics available with us. So they are actually available means they're kind of approved. We have already talked about some of these. I'll start with the nintedanib first and then to the other ones. The nintedanib was tested in the inbuilt trial in 2019, which Dr. Sehgal just alluded to some time back. And this was the census trial. This was also talked about for SSC ILD, so systemic sclerosis ILD. We are not talking about this. We'll talk a little bit about this one because we are talking about progressive fibrosing ILDs. So again, in this, so these criteria you all know, we have already talked about this, the intervention, placebo or nintedanib. Primary endpoint, as already mentioned, was the FVC decline at 1 year. So most of the trials have been up to say 1 year, 6 months to 1 year. But now for this, I'll show you that we have some longer follow-ups as well. The trial result was that there was the rate of decline of FVC in the experimental group was lesser, slower, And as you can see here also, this is the experimental group. The rate of decline of the FVC was slower as compared to the placebo arm, meaning thereby that it is having some beneficial effect. So the key learnings from the inbuilt trial basically were that PF-ILD can be now identified in the clinical practice. So that was a new concept at that time. Nintedanib slows the decline of FVC and lung function in this particular entity. It may be used as an add-on or as first line also, because some patients in this trial were put on first line or as an add-on, but side effects were pretty common and they needed to be monitored. Now, in this very trial, then they did a bit of a sub-analysis. So this came up later, a couple of years later, that how it fared in Asians. So they found that the results in Asians with PF-ILDs, also the results were the same. So it did the same kind of a benefit among the reduction in the FVC in these patients as for the main trial. But mind you, something to note, none of these Asian patients were actually Indian. This was mostly a Chinese and a Hong Kong group over here. So that is a kind of thing. We cannot directly extrapolate this to this thing, but overall it did benefit. Now, originally it was only a 1-year trial, but now we have some long-term data as well. So the long-term safety and efficacy has been published very recently, as you can see, just this year. And this was the data from the inbuilt on trial. They looked at the patients for a period of almost 4 to 5 years now, and they found that the benefit of nintedanib continued. So over here, the rate of decline was kind of there, but it was not to that level as it was seen in the placebo of the original trial. So what they concluded was that, and some patients in this were actually started on nintedanib during this trial because they were on placebo in the original trial. So in both the groups, the change in FVC in this in the experimental group was consistent with the change in FVC in the original nintedanib group as well, meaning thereby that long-term benefit also sustains. That is one thing that we can know. The next antifibrotic is the pirfenidone, and pirfenidone was also tried in almost 5-6 years back. Both these antifibrotics came at the same time, and when they looked at this in a phase 2 trial, a short-term 6-month trial, it was found that it also had benefit in slowing of the rate of decline of the FVC as compared to the placebo. Now, basically, then another phase 2B trial, which was the relief trial, came up later. Unfortunately, this was ended prematurely due to poor recruitment. Although the primary endpoint was there, it was just about met in this study. But because it was terminated early, they were not really able to make any conclusive statements. But the pirfenidone here also kind of slowed the decline of FVC as compared to the placebo. And but in DLCO, it did better. It improved not improved, but again, it kind of reduced the rate of decline of DLCO better as compared to placebo. Then comparing both the two, meta-analysis were done, but we have only a couple of kind of RCTs available. A meta-analysis to see the clinical effects and the risk factors and the adverse events. And here, if you see if we measure the rate of decline of FVC, both of them, pirfenidone, there is a kind of a advantage favoring the antifibrotic, for nintedanib also favoring the antifibrotic. So both these work well. For percentage predicted FVC also, they work well. But when it comes to mortality, neither of them actually had any significant effect on overall mortality. So that is again something to be looked at. For lung function decline, yes, but for mortality, they have not been proven. So the big question comes, which one to prescribe? That is always the dilemma, isn't it? So again, as far as efficacy is concerned, because there is no head-to-head trial between these two, the debate is not settled. Both of them work well. Both of them slow down the level of decline of lung functions, and the rest of the things can be then depending upon all these things and the patient-to-patient profile. One can maybe try and make a decision that which particular antifibrotic will suit that particular patient more. So whether it is a pill count, whether it is the side effects, whether it is the presence of anticoagulation therapy going on, presence of ischemic heart disease here, probably pirfenidone has a slight edge as compared to nintedanib. Uh, the impact on quality of life is there better, is equal for both. Prevention of acute exacerbations also, both of them work well. So if you can, as you can see, there is very little to choose between them. Maybe the side effect profile, patient tolerability, the cost, all these things are going to matter more as of now rather than the actual efficacy. So there are still dilemmas in the PF-ILD pharmacotherapy. So is there any benefit of adding this to background steroids or immunosuppressants? Now, this was a consensus statement. This was from one of our colleagues only from Mumbai, and this was published recently. A kind of a expert group sat together to address a couple of important questions which were of practical importance, and they decided that apart from certain types of ILD, antifibrotic medication as of now should not be considered as a first line therapy, especially for those in which we can give immunosuppressive therapy. Then can antifibrotics and immunosuppressants be combined upfront or only given sequentially? So upfront is not as of now advisable, but most often than not, it should be given sequentially once we establish the diagnosis of PF-ILDs. How long should the other things be continued, the steroids and the immunosuppressive therapy, and when should they be weaned off? Needless to say, every attempt has to be made. So these are all kind of practice points. They are not very heavily backed by evidence. Attempt should be made to withdraw the regular corticosteroid, and we should give an alternative immunosuppressive agent at the same time. The dose of these will vary from patient to patient, so no clear consensus on this. A question also comes why antifibrotics should not be given upfront for all ILDs who have got fibrosis, because there is insufficient evidence for the same. That all antifibrotics, whether they work for all PF-ILDs, it is not very clear except for IPF. That is the only thing. In some like SSILD and RAILD with the UIP pattern, there is some evidence that it might benefit, but in most others, still immunomodulatory therapy is likely to work pretty well, especially for sarcoid and HP. So there are certain unmet needs. It is a relentlessly progressive disease, the lung function continues to decline. Adverse events are high, it is costly. We also don't have any biomarkers, so we need more efficacious and newer medications. So do we have anything as of now? So this just shows the pipeline of the newer things which are under experiments. And so this was already what we have seen, nintedanib, pirfenidone already seen, but now we have some PDE4 inhibitors which are under trial. We have LPA antagonist. LPA is the lysophosphatidylate antagonist which are under trials, and we also have inhaled treprostinil which are now under trial. So these are some things about which I'll just spend one minute each and tell you. So the potential of PDE4 has been kind of recognized in PPF very lately, and that is nerandomilast, which is a PDE4 inhibitor, having anti-inflammatory as well as anti-fibrotic effects as well. It is oral, that's also important, lesser of GI side effects, and in some initial phase 2 studies, it was found to stabilize lung function irrespective of the antifibrotic use. So now phase 3 studies are under trial, and that is by the name of Fibroneer. This is something which is under trial. Maybe by in a couple of years, we will be seeing more of that. So these are just some press releases that came. Last year, it was said that actually the results have come, and they said that it meets the primary endpoint. It has not yet been published, but this is the press release which said that it has met the primary endpoint, which is the absolute change in decline of FVC versus placebo. It's a large trial, pretty large trial as you can see. And this was another news coming up very recently, the same thing, but again, still I could not find the actual publication to this. So let's wait and see that if we get the actual paper. The next experimental therapy now which is under trial is the LPA1 antagonist, and this is something which came up this was a phase 2 trial a couple of years ago in IPF and PF-ILD both. This is a BMS agent, and they also reported that it reduces the rate of lung function decline in IPF in this. The PPF part has to be seen, and we have to kind of see whether it kind of works in that as well. But in this trial, at least the phase 2 trial, I will only focus on the PPF part. Here, this is the IPF cohort, PPF cohort, placebo, and the two doses of this particular agent, which is admilparant. This is basically a LPA1 antagonist, and this was tested. And you can see here, the blue one is the experimental drug. The rate of decline of FVC is lower in both the doses of experimental drug compared to the placebo. Similarly, you can see over here as well. So meaning thereby that there is some benefit, some promising kind of results coming out. So they concluded that both the doses of this particular agent, the admilparant, slows the lung function decline, is safe, well tolerated. So phase 3 trials are advocated. Now, The last one that I'll touch upon is the inhaled treprostinil, which is also now emerging as an option for ILD because it has been found to have some antifibrotic effects. Now we know that it is already approved for treatment of PH related to ILD. We know that, and this was the increased trial in NEGM in 3-4 years ago. Now there is data to show that there is some antifibrotic effect of this agent as well, and that is why in that same trial a post hoc analysis was done where they looked at the FVC with this agent in ILD with PH, and they found, as you can see, that the FVC decline basically was less in the patients who had received treprostinil in ILD in this particular group of patients. So that was just about the new experimental therapies. I think one should know because in the next couple of years we might know if any of them is likely to work, so that we have something more than the two antifibrotics we have as of now. The last part, monitoring. Monitoring is continuous, but we don't know how frequently, maybe 2 to 3 months or even earlier. PFT 3 to 4 months, but if stable disease, we can make it 6 to 12 months. Radiology, HRCT every 6 months. Otherwise, it can be annually also after some time, and other things depending upon the need. So this is how we monitor the patient. Pharmacotherapy, beyond pharmacotherapy, all this we have already seen, so I'm not repeating. These are all standard therapy for the chronic respiratory diseases. This mimics very closely to the IPF management, so that is more or less what we have to do. The last thing is a lung transplant in ILD, and again, we all know the referral criteria and the listing criteria for ILD, and this, if they are met, then that means that one can refer and one can list for the lung transplant of these patients. And here we can also see that lung transplant for ILD is on the rise. You can see the yellow one over here, this part. More and more patients with ILD are undergoing lung transplant over the last 15 years. The survival curve, again, you see this, the yellow ones. This one is somewhere in between. In the last couple of years, if you see year by year, unfortunately, survival has not really improved much even after lung transplant. So we'll have to see whether we get to something better in the next couple of years. So with that, I think lastly, management algorithm, already you know that if you have a PF-ILD, you do the diagnostic test, you are confident, you treat, disease stable, follow up, disease progression, it becomes a PF-ILD, and then add the antifibrotic therapy here, not somewhere here. That is one thing. And still so many unanswered questions. So I think we are going to have a lot of more discussion on this. We don't know diagnostic criteria, validity, objectivity of the radiological progression. So many questions. Which antifibrotics? Still not very clear. Is there a uniform response to antifibrotics in all ILDs? Still we don't know. Can we stop all these drugs after antifibrotics? We don't really know. So to conclude, fibrosis, either existing or newly developed, and progression generally portends a poor prognosis in all ILDs. Hence, we have to very carefully and very closely monitor the clinical course with PFTs and HRCT. We have only two proper antifibrotics as of now, with and without immunomodulator. They are the preferred treatment modality. Although, as seen, newer modalities and newer agents are under active trials. Hopefully, we will have some better agents soon. Apart from that, all supportive therapy has to be given as for any other ILD. Ultimately, the only potentially definitive therapy still remains the lung transplant, and that should be offered whenever feasible, with, of course, all the caveats of its complications. So with that, thank you very much.
Thank you very much, sir, for this thought-provoking and excellent lecture. Sir, I just want to ask one question. Sir, if patient is not tolerating antifibrotic therapy or he is group of non-IPF PPF group, patient, how will you manage that patient?
So it's a non-IPF patient and he's not tolerating any of the antifibrotic therapy. So one thing would be you can try and decrease the dose. For example, nintedanib, instead of the 150 BD that we give, we can maybe stop it for some time. Maybe try 100 mg BD. That also is one. And we have to see what is the problem of tolerance. I mean, if it is something very serious, then of course we have no option. If it is something which can be managed GI wise, then we can maybe give something to take care of that. Otherwise, as of now, I don't think we have something that can really actively slow the lung function decline apart from these two agents. We can stop it, we can try again, go at a lower dose. That is probably the practical approach.
Thank you, sir. Thank you very much.
So any comment regarding this dual antifibrotics? this subset of the patient? Have you some experience in what the literature says?
Uh, so yes, so there are there is no big trial, but there are case reports and there are some case series personal experiences. But I have no personal experience. I have never combined with this. We may ask the other of the groups. But again, the long term follow up is something which we don't know, and the long term side effect profile also, because tolerance again becomes a problem. Both of them have got significant GI issues. So if we combine both of them, that becomes the problem. And also subtherapeutic, there is a lot of kind of, pirfenidone, for example, we say we go up to 2400 milligram per day, but that is not very easy to reach. If we combine that with nintedanib, and then we go to the topmost level of dose, so then that leads to significant side effect, which again the patient tolerability is a problem. The efficacy wise, I am not aware and I have not come across any study which has systematically looked at the improvement of dual antifibrotics vis-a-vis solo antifibrotics. So that I think would be something to look at, but there is no structured trial to my knowledge for this.
So one more very practical question, that nintedanib, the one of the most common side effect is the loose motion. So what strategy you apply for these patients? You change the molecule, or you step down the doses, or you do something else?
So first I stop it. So if it is severe enough to trouble the patient, then first I stop it for a couple of days and let him settle down. Then maybe give a challenge once more. If it happens again, then try a lower dose. And if it is not improving, then I think I'd like to change the antifibrotic.
Any question from outside? Yes, please.
Sir, I have one question. If a patient is on immunosuppressive therapy and then he started on antifibrotic therapy, then what happens to the immunosuppression? Do we decrease it, or do we increase the dose, or do we leave it as it is?
So we have to see the activity of the disease also. Now, if the activity of disease is gone and it is a purely fibrotic disease, then the immunosuppressive therapy also may not really be required. And why to subject a person to the side effects of an unnecessary immunosuppressive therapy? So we have to, that is why the continuous monitoring of the primary disease also has to, PPF and PFILD will be the end stage of the initial insult. So whatever is your initial disease, that should be first controlled. If it is controlled, then your immunosuppressive therapy can be minimized, or even you might consider stopping it and see.
Sir, we have been told by the organizers Dr. Jindal has a flight to catch, so we'll have to wrap up things. So, thank you so much, sir, for the wonderful lecture, and I would hand it back to the organizers. Thank you. Yeah, thank you. You can ask it after the CME is over, Ajit. Yeah.
Thank you, sir. Thank you for your insightful lecture. So it's time for felicitation. I request Professor K.V. Gupta, Department of Respiratory Medicine, Iras Medical University, Lucknow, to felicitate Professor Anant Mohan with a token of small tribute to your exceptional contribution. Next, I request Professor K.V. Gupta to felicitate Professor Naveen Dutt with a memento as a sign of enduring appreciation. I request Professor K.V. Gupta to felicitate Professor Subodh Bhatt to kindly with a memento. I call upon Dr. Abhishek Tandon to kindly accept the memento as a gesture of thanks. Next, I call upon Dr. Nirupam Prakash to kindly accept the token of appreciation. I request Dr. Muhammad Hamid to accept the memento as a sign of our appreciation. I call upon Dr. A.K. Singh to receive the memento as a token of our gratitude. Thank you.
Thank you. Coming to the penultimate session of the day, that is the optimizing ILD care based practices for supportive treatment and monitoring by Professor S.K. Jindal. For the session, to chair the session, I will call Professor K.B. Gupta, Professor Iraj Medical University, Lucknow, Dr. Anil Kumar Singh, consultant pulmonologist from Chandan Hospital, Lucknow, Dr. Jugendra Singh, consultant pulmonologist from Medanta, Lucknow, and Dr. Atul Tiwari, assistant professor, Department of Respiratory Medicine, Benares University, who is also the proud alumnus of this department, pulmonary medicine, AGPGIMS.
Good afternoon. Now, first of all, sincere thanks to organizer, Professor Aloknathji and his team for inviting me and giving this opportunity to chair a very important session by an eminent speaker. Now, Professor Jindal needs no introduction. He is a very well-known figure in the field of the pulmonology, nationally, internationally. He joined in the field of the pulmonary medicine and mentor of the mentor. I say teacher of the teachers. Former HOD of the pulmonary medicine, PGI Chandigarh. He has been honored with the Outstanding Educator Award for scientific contribution by American Society and Lifetime Achievement Award for the Indian Chest Society. But Jindal is a past president of the Indian Chest Society, Indian Medical Association Chandigarh, and other national associations. He has also been a member and chair for various experts and scientific committee, including the National DOTS Plus Committee, Journal Operational Research Committee for the tuberculosis.
This is the point.
He has been the associate editor for two important and widely read journals, the Chest and the International Journal of Tuberculosis and Lung Disease, and member of the Educational Board, editorial board of the several journals. Besides his books on the oxygen therapy and quit smoking, why and how, he has edited a comprehensive 2-volume textbook and handbook of the pulmonary and critical care medicine, which all you know. Sir, please.
Well, thank you, Professor Gupta. I'm very grateful to Professor Alok Gupta, Mansi, and their team, you see, for giving me this opportunity to come here. Of course, it is always a pleasure to come to SGPGI, and I have come here several times in the past as well. What I am going to do is just review what has been said in the earlier session, you see, very briefly. In fact, by and large, the issues have been pointed out. The supportive care, you see, the optimization of overall care for a case of ILD. Basically, optimization is the art of medicine, you see. We always learn that medicine is an art as well as a science, you see. We generally focus on the science component more than the art component, you see. So art, of course, involves the multi-pronged strategies, data-driven decisions, tailored treatments, and patient interactions to individual needs. I think that is what is very important. We have discussed, of course, all of us are aware of the problems of tolerance, intolerance, toxicity, cost, and so on, you see. So the patient factors are very, very important, you see. So meeting the needs of individual as effective, reliable, and safe standards established by, of course, all these things have to be, cannot be ad hoc decisions, you see. They have to follow certain principles and guidelines. See. We have already learned in the previous session that all ILDs, the treatment of the underlying cause is the most important. to identify whether it is hypersensitivity pneumonitis, whether it is CT related, or whether it is fibrosing ILD or sarcoidosis or so on. And symptomatic therapy for cough, breathlessness, sarcopenia, sleeplessness, and other distress. I think that is something which is very important, often just dismissed as a passing kind of remark. So the goals of sportive treatment are, of course, multiple. The symptom-centered approaches. All of you know, especially those who are in private practice, they know that the symptoms are the most important problems which the patient faces. He may not be concerned with the overall longevity immediately, you see, although nobody wants a reduction in life. But if you say that this treatment will increase your life to by 6 months or 1 year, for him, cough and breathlessness are the most important things, at least when he visits the clinic. So best sportive care is very important, optimize quality of life care, and then caregiver-centered management. You see, that is also because the families normally get involved in the care in this country in general. You see. So we generally ignore that component, that they spend a lot of time, money, and sometimes their jobs, vacation, and so on, you see. So that is very important in this country in particular. Patient-centered management, and then of course, finally, it is the end of life care, you see. And there are several determinants of treatment which we all know. For example, cause, whether it is primary or secondary, I have already pointed out. What is the age and physical condition of the patient? I think that is an important determinant which we several times forget. Treatment of a person of 50 or 60 years may be different than the treatment of a person aged 80 or above, you see. And we now have a lot of patients, especially with reference to IPF, who are aged and old, whether it is acute or chronic onset, active or progressive symptomatology, severity, functional, and these points, of course, are already discussed, and but we must keep in mind all the time, you see. Now we'll just briefly discuss some of the important symptoms in ILD. Cough has always been pointed out because that is one of the most distressing symptom these patients often have, you see. We know that the non-specific antitussives like non-opioid cough suppressants, disease-specific drugs, there are a lot of antihistaminics, decongestant, and antitussives, you see. And treatment of comorbidities, of course, is always important because sometimes they not only aggravate but compound the causes of cough. Then, of course, the use of antifibrotic drugs themselves, you see, which Dr. Anant Mohan had just talked, you see, that is also an important cough relieving treatment, you see. I'll just, this is a kind of very old, 150 or 200 years old photograph of a one-night cough syrup, you see, when the opiates and derivatives were frequently used, you see, for refractory cough. Factually, opioids have been the most effective cough suppressants. Unfortunately, for different reasons, you see, they are not that easily available nowadays. Even codeine, you know, is a very good antitussive agent, but not really available even for such patients. Then there are other agents which have been used off and on, you see, like gabapentin, thalidomide, diamorphine, subcutaneously. And finally, of course, it is a multimodality speech pathology therapy, which we generally do not really stress upon, but may be important in some of these patients, you see. What does multimodality cough suppression therapy involve, you see? Of course, it may fall in the domain of the counselors or psychologists and psychiatrists. Patient education about the cough, the causes of cough. The mere explanation sometimes helps a lot, you see, that how is the cough generated and what is the root cause, you see. Then, of course, other strategies, cough suppression strategies like breathing exercises, swallowing technique, sometimes even asking the patient to swallow slowly. And distraction techniques are also helpful. Laryngeal hygiene is important. Laryngeal hydration is important because dryness is a very common uh, symptom which these patients complain. Avoiding throat clearing. Some of these patients you might have seen in the OPDs, they are in the habit of kind of barking cough, you see, or they kind of try to clear throat again and again, although nothing is really lying inside. Reducing laryngeal irritation, of course, environmental modification as much as can be made are important. Sometimes even simple laryngeal massage, asking the patient or some caregiver to do that, you see. And finally, one can seek the kind of advice of counselor, psychoeducational counseling, motivation, adherence, and other psychiatric management techniques can be employed and quite useful. In fact, if you really want to treat, and if the patient is also, of course, interested, you see. Then the second important symptoms is breathlessness, which is of course, one of the most important symptom. Here, specific therapies are very important, and in details, we have discussed the role of anti-inflammatory drugs, corticosteroids, immunosuppressants, and antifibrotics. Bronchodilators may help to some extent. Inhalation therapy, both with inhalers as well as nebulizers, and oral bronchodilators can be used sometimes. And then non-specific sports like for cough, they are also important. Pulmonary rehabilitation, management of GRD, breathing techniques, sedative, and multimodality psychoeducational and calming techniques, you see. And finally, of course, is the education, oxygen therapy, and lung transplantation. Like for cough, I think for dyspnea also, very detailed treatments have been discussed, the non-pharmacological treatments like explanation, reasoning, acknowledgement of symptoms and addressing the anxiety, education of patient and the caregivers, handling sudden episodes of dyspnea, panic, activity pacing, I think. General measures like in the environmental control in the room and loose clothing, etc. Some of these things do help, you see. Patient may be practicing some of these things, but I think doctor can also support and insist upon, you see. Then, of course, supplemental oxygen, we have already talked about earlier by Dr. Anant Prakash as well as the other speakers in the previous session. Chronic respiratory disease, whenever there is arterial oxygen desaturation or saturation is less than 88%, measured at rest or in stable conditions on two separate occasions, or whenever there is PaO2 of 55 to 60 millimeter mercury, if at least one of the following criteria is present, hematocrit 55, more than 55%, and pulmonary hypertension. In fact, these criteria have been derived from the LTOT criteria used for COPD. There are no large-scale studies in ILD done at present, but by and large, the same criteria are followed, which were followed in the COPD trials in the past, you see. And exercise capacity in these patients, of course, is in exercise-induced hypoxemia, it improves. Oxygen provides no additional benefits in terms of exertional dyspnea for IPF patients without the resting hypoxemia. I think then it is an important point. Like in COPD, it is a different thing. Here, there is no evidence to say so that it provides any benefit in patients who do not have hypoxemia, but it may act as kind of palliative therapy in some of these patients. Oxygen improves exercise tolerance, alleviates exercise-induced hypoxemia, and reduces dyspnea. I think that, of course, is, as I've already said in these indications, you see, that if patient has exercise-induced or sometimes nocturnal hypoxemia, and if some of these conditions are present, there is polycythemia and pulmonary hypertension, then it can be used. I have already said that, and This can be assessed with the help of 6-minute walk test, most commonly used test for exertion at desaturation. Other tools like Deox score can be used, which has been used in some trials nowadays. And so in these patients, ambulatory oxygen therapy can be used as has been used for COPD, and these patients are certainly helped. Nocturnal oxygen therapy for ILD, it is still, there is no real study to say so, but it may help, you see, and it may have a palliative role. But in those patients who have complications of hypoxemia, as I said earlier, I think it may be helpful. So it is just for the time being a kind of gray area, but certainly palliative, you see. Pulmonary rehabilitation has been said repeatedly, and that is perhaps one of the most important issue or most important treatment which can be given to these patients. And recent evidence, it does suggest that benefit from a tailored exercise program is there. It includes education and psychosocial sports. And you note that pulmonary rehabilitation is a multidisciplinary kind of approach, you see, where it is not only exercises or nutritional sport, it also involves psychological sport, social sport, education, and a training program which is really tailored to the patient's need. So there is a statistical significant improvement in 6-minute walk test in the rehabilitation groups, and the mean difference was significant. Statistically significant improvement in total health rated quality of life score, you see, that also is important. I think the quality of life is very, very important, which we often forget. It is just, it is never measured, although we keep on saying SG, RQ scores and other scores, etc. But not much stress is given upon them. Then there is pulmonary hypertension. Of course, that is an important issue in ILD because there is chronic hypoxemia, so that leads on to ILD and vasoconstriction, vaso remodeling, perivascular fibrosis, and hypoxemia. Then there could be thrombotic angiopathy, pulmonary emboli, elevated pulmonary capillary bed. So there are a lot of factors, you see, and some of these patients are genetically predisposed, perhaps, you see. Treatment for pulmonary hypertension is practically same as for hypoxemia. Oxygen is most important. Diuretics may be given if there is fluid overload. Anticoagulants may be needed. Pulmonary rehabilitation. The anti-PH drugs, you see, by and large, they are of no use. I think that is same as for again cor pulmonale or COPD, etc. Some have been tried and found to give some benefit. I won't go into these details. Perhaps, as said earlier by Dr. Anant Mohan, some of them can perhaps be used. Vaccination, again, no specific studies for vaccination in IPF in particular, but for respiratory diseases, there are general recommendations for COPD for that matter, annual influenza and anti-pneumococcal vaccine. In the Western countries, especially in the US, some other vaccines are also advised, like COVID-19, Tdap, especially in those who were not vaccinated earlier in adolescence. Zoster vaccine, shingles, again in this country also it is being recommended, in particular for COPD, but for adults over 50 years or and older, I think one can again kind of translate that same recommendations for IPF. Lung transplantation is the only therapy of protein benefit for to give relief from most of the symptoms, and it can provide benefit, but you know the difficulty. I won't go into these details. And when to consider, again, for patient age, which is perhaps a relative criteria nowadays. In fact, one of our patients has been 70 or 71, in fact, you see, who was otherwise fit and was operated. And these are some of the criteria. I won't go into these details. So optimum care needs regular monitoring as well. Monitoring, of course, has been talked about earlier again. We need to monitor for progression of ILD as well as for other multiple assessments like risk factors, and home monitoring is kind of all these monitoring is required uh, for any complications, for any drug toxicity, for sportive care, and so on. You see, and monitoring of patients, the criteria are variable. I've just tried to summarily put here. You see that every 3 to 6 months, one should symptomatic assessment, health-related quality of life, and lung function assessment with the FVC and DLCO can be done. Every 6 to 12 months, 6 months walk test, and every 12 to 18 months HRCT, you see. But these are not kind of fixed kind of recommendation. They can vary depending upon the patient's requirement. Um, in between, of course, sometimes X-rays are required more frequently for any complications, etc., etc., to monitor the drug toxicity, blood test, hematological, biochemical, and others may be required. And nowadays, there is also a lot of stress on home monitoring, wearable devices for remote monitoring of respiratory rate, saturation, and other relevant. I think this home monitoring and wearable devices are coming for almost all chronic diseases, whether it is COPD, ILD, or sometimes even tuberculosis, you see. So take home message, of course, that optimization of curative and sportive therapies is an important composition of an ILD balance. I think one must maintain a balance between the sportive and the therapeutic or the curative treatment, you see. Antifibrotic drugs constitute one treatment option with progressive pulmonary fibrosis, both to decline progression and to improve the quality of life, has been discussed by previous speaker. But symptomatic treatment is that's what I'm trying to stress upon is most critical for all kinds of ILDs. Cough and breathlessness are most distressing, which need better management to improve. And finally is the discontinuation of specific therapy and resorting to palliative care is recommended for end-stage disease. I think that is what has been recommended for a lot of incurable cancers, advanced metastatic cancers, even the advanced disease. If patient is not really going for transplantation, that discontinuation of even specific therapies like antifibrotic drugs, which are producing more potential toxicity and other issues for the patient may be discontinued. Well, thank you very much for your patient listening. I think.
Thank you, sir, for that beautiful deliberation. That is like listening to great teachers, that a complex topic is delivered in such a simple way that it looks very simple. Are there any questions from the audiences?
Okay.
Now it's time for the felicitation. I'd like to call Professor Aloknath to come to the stage for the felicitation program. First, Professor S.K. Jindal. Professor K.B. Gupta. Dr. Anil K. Singh. And finally, Dr. Atul Tiwari. Now I would request Professor Aloknath for the vote of thanks and calling it a day. Okay, I request. I request. I request Prashant sir, Dr. Prashant UP for the vote of thanks as.
So finally, we come to the end of this CME come workshop under the aegis of ICMR's network of pulmonary fibrosis. It was a very pleasant and I mean heartwarming experience for a very fruitful gathering today. And I sincerely would like to thank all the participants, delegates, faculty, and all the members of the supporting team who have really put a hard work to make this CME success. So I would like to thank the organizing team, especially Dr. Mansi Gupta, Dr. Prashant, who were the main organizers, and Mansi was the organizing secretary of this workshop. She has really single-handedly, I mean, organized this workshop with so much perfection that is really remarkable. And she has really did it in a very short span of time and with a very short notice, because this was to be done under the ICMR program, and it was a mandatory workshop, and she was given only 1 month's time to put this up for all of you, and it had been really really very good effort by her. And to assist her, Dr. Prashant, who is the new faculty member and our own alumni, first batch of DM pass out from our institute. He has he supported Mansi, and she with I mean Prashant with her has did a very wonderful job for organizing this workshop. And I would like to thank all the ancillary staff, the complete nursing officer of our department, including the ward and ICU, who were also continuous support to organize and I mean make the function, all the parts of the function look very beautiful. And along with that, all our ancillary staff, industry members, and supporting staff from our department, and all the supporting department, electricity department, horticulture department, and I mean the civil department, for extending all kinds of support which we required for this workshop. And once again, I would like to thank all my students, residents, who have really worked hard and worked very hard in a very short span of time to make this conference or a workshop to be conducted in a smooth manner. And once again, I thank all the participants and faculty members who have taken out their time from their precious time from their busy schedule to participate in this conference and make it a success. Thank you, everyone.